Good morning, Cheryl. I am so excited to have you on the podcast this morning as a fellow hygienist and myofunctional therapist. So welcome on. Thank you for taking the time to come and chat with us.
Thank you so much. I always enjoy our conversations. We have too much fun and we have a lot in common. So I'm looking forward to a great conversation and,
Yes,
just reaching out and
absolutely.
teaching others more.
Yeah, well, let's start by sharing your story with how you got into the myofunctional therapy world and kind of your transition from hygiene to strictly just myo.
Great question. And I think about it a lot. It's like, what led me here? How did I get here? Like that song from the Talking Heads. Well, it takes me all the way back to high school. I love healthcare. I've always had a desire for healthcare. And back in high school, I was kind of deciding, do I want to be a nurse or a dental hygienist? And went through a health studies program, investigating both avenues. And to be quite honest, I decided hygiene because I like the hours. I was afraid as a nurse in the hospital, I'd be working nights and weekends, and that didn't fit in with the lifestyle I want to have because I'm a big sports fan as far as athletics, skiing, and racing sailboats and stuff like that. So I wanted to make sure I had my weekends and my nights as sacred. So I went into hygiene. Loved doing clinical hygiene. I'm licensed in 3 states, Florida, California, and then Maryland, and worked in some amazing practices in almost every kind of dental setting there is. Mm-hmm. The problem that came for me was twofold as the evolution of my dental career. One was I always have been a lifetime learner, always wanted to learn more, wanted to understand things in a bigger concept. And then I saw patients who were struggling with things, and I was just considered to be the tooth cleaning lady. And I wanted to do so much more. So that became a little internal struggle. And the second part of that was my body. So as a hygienist, you're expected to do the same thing all day, mentally and physically. So my right arm was having tingling, numbness. There was a few days I couldn't even hold the scaler because of the damage I was doing with the postures I was putting my body in to be able to see that, area of the mouth that you had to do silly things with your head to see. So that kind of started my journey through hygiene, and then thinking, what else is out there?
And I know we had talked that I think a lot of it had to do with your son, right? Your son presented with OMDs that I know kind of brought you into that myo world.
Correct. Well, it's interesting because once you put on myo eyes, you see things from a whole nother perspective, a whole nother side of the coin. And it's kind of like when I talk about the roof of the mouth in dentistry, when we look at the roof of the mouth, we're looking at the palate, which is important, the palatal shape and width. But as an ear, nose, and throat doctor, you're looking above that same bone through the nose, and you're looking at the sinuses. So, there's 2 sides of the coin. There's 2 perspectives we can see things through. And when I took my original course with Mary and Diana at the IAOM, International Association of Oral Facial Myology, that was my introductory course. The interesting thing too that we haven't talked about was I didn't realize I had a myofunctional disorder, and everybody has a story. And I think the more stories we have, the more we relate to, the more passionate we get. I sucked my thumb for an extended period of time. I had my tongue on the floor of my mouth. I had a tongue thrust swallow, and they said to me, Cheryl, it's a good thing you're here in this class. And they used me as an example. And I thought, well, why are you doing that? Because I'm here to help others. I am not here to have you picking on me. I had no idea. But even though I was an oral health specialist, I had never learned there was a proper place for the tongue. Isn't that crazy? What about you?
Oh my gosh. Yes. I remember just sitting there and just being so mind blown. And obviously the first thing you do is you check yourself. How am I breathing? Where's my tongue? Where are my lips? Where's this? Where's that? How do I do this? Do I chew on both sides? Do I chew enough? Do I swallow with my tongue on top of my palate? Yeah. You totally you go through that checklist. And it's so funny that, you said that about your intro course. So my sister-in-law is currently taking the intro course through the AOMT. She's in it right now. and they had their live cohort this past weekend. And she's like, they asked for a volunteer, and my sister-in-law doesn't really like to be center attention, but she was like, I knew that I'd be a great learning experience. She's like, so I volunteered myself. And she was like, and then I realized that they were videoing it. And I was like, oh man, what did I get myself into? But it is a great learning experience for everybody watching, and even for ourselves to learn, because we learn nothing about this in hygiene school.
Correct.
It's insane.
And then you also have that we should be learning this. We should know this. This should be part of what when we're doing our oral cancer screenings, we're looking at the same things from different, again, MyoWise perspective. So it takes no extra time out of our schedule to at least understand what we're seeing. So then we were talking about my son. So when I finished my course and I went home for the first 2 months, I did the program on myself. I'm like, I can't do these things. I cannot do these exercises. How do I teach somebody else these exercises? I cannot hold my tongue there. How do I do that? So I had to work on myself. But as everything was unfolding, it brought back lots of memories of my child and my son's childhood, where we never connected the dots, and I was chasing symptoms and not root cause. So he was breathing through his mouth since he was just a little baby, snoring, gasping for air. I would ask the pediatrician, about the mouth breathing, and, they were not real upset. And then he had chronic ear infections. He would be screaming for the first 3 years of his life, unless he was on antibiotics or had tubes in his ears. I think he had tubes twice.
Wow.
He had large tonsils. So when I would take him to the doctor to have the tubes put in, I would say, well, what about the large tonsils? And they said, well, we'll wait and watch those, but we'll put tubes in his ears. So he was snoring, and then he started grinding his teeth when the teeth came in. And I was, as a mom, as a hygienist, I knew he was wearing his little baby teeth out. And I didn't like hearing the snoring and the gasping and the grinding the teeth, but I felt very powerless. And I did take him to doctors and didn't really get to solutions for this poor little guy who was suffering and not sleeping. And, of course, when I thought I was a human pacifier with the breastfeeding, I thought that was just normal. I didn't know what was normal and not normal. And you learn all these things and you're like, wait a minute, putting all these pieces together. So the big part of my son's story, and a lot of people that know me know my son's story, is he also had a speech disorder. And that's where for him, it presented the most. For me as a mother and a hygienist, the breathing and the grinding his teeth and the chronic ear infections and the screaming and pain. But for him, his name was Rick, and he couldn't lift the back of his tongue. And so he couldn't say his own name. And so it came out as Wick. And when we moved from San Diego, when he was little, it was cute when he was Wick, when he was 3, everybody thought it was adorable. But when we moved to San Diego, or from San Diego to Maryland in the middle of 5th grade, it was not cute when he entered 5th grade and he called himself Wick. And the bullying started, and he stopped talking, and he became an introvert, though he's an extroverted personality. And not until, and I was told he didn't have a tongue tie because it was some people call it submucosal, some people call it posterior. It's not as easily recognized because he could lift his tongue. He just couldn't lift the back of his tongue. So I finally took him to an oral surgeon between 8th and 9th grade and said, something's got to go. Let's just take care of this. He was in speech for 6 years, all that stuff. And so we did the frenectomy, and a month later, with working with a speech pathologist on, range of motion, elevation of his tongue, he said his name for the first time entering high school in 9th grade. So it was so profound for him because he could become the person he was supposed to be. He was breathing at night through his nose, sleeping well, not snoring, can say his name. And it just changed his life, that he could be an articulate, understood person and be the best person he could be. So every time a patient comes to me, they all have the same story. So, right? The same story, different human. So it's very similar. The chronic mouth breathing, the not sleeping well, the snoring, the ear infections, it can manifest in many different ways, but it's often the same story through the lifespan, correct? Don't you see that?
Oh yeah. And I'm glad that I know you were sharing your son's story, but something of that I'd like to lead into our next topic, how when we're talking about lingual freedoms, we cannot just look at the ability to elevate and the ability to protrude, because that's not just the only two functions that we need to be able to do. So if you want to talk about kind of maybe even how you explain it to parents when, because as a parent that, isn't trained in this field, if you see a child that is able to lift their tongue up or able to stick their tongue out past their front teeth, I could see where it might be like, well, I don't understand. How could they possibly be tied? They can do this and they can do that. So if you want to share how you would explain it to parents, because I think for a lot of myofunctional therapists, and I'm learning obviously a lot from now lecturing myofunctional therapy, that's one of the biggest things, like hygienists, speech, whoever's doing the myo, they want to be able to translate the correct message clearly to the parents without, criticizing them or just getting them kind of confused and speaking in more scientific terms. So if you want to share with us how you would explain that if I was your patient or parent sitting in front of you.
So that's an excellent, excellent question. And my brain's like going into all these different directions and I'm trying to go, okay, I got to remember this direction and that direction. But the first thing I always start with is how I didn't know how to recognize it and how many mistakes I made through my 30 years of being a hygienist because I wasn't trained in it until I had the extreme privilege of training under the best there is that I know personally. 5.5 years ago, I trained with Dr. Zoggy when it was under the umbrella of the AOMT, and Irene, help me with it,
Markazan
was there, and I trained under her technique. And that was 5.5 years ago before he even had the Breathe Institute. I've trained with Autumn with the tongue tie specialty course. I've trained with, gotten to know Richard Baxter. I went to the American Laser Study Club last, before COVID. I was
yep.
all I was like, I felt like I was like in a movie star convention, it's like, what? There's so-and-so. And a lot of them I saw you've actually interviewed on your podcast, but it was just, I was starstruck.
Yeah.
And just to be around people that are forward thinking and so just doing the studies and the research and the investigation and learning from them. So the first thing I tell patients is that I didn't know. And in our school, in dental and medical, we do not have the advanced training unless we go to all these courses and unless we have a lot of traction. And so the next thing I want to say is my perception has actually changed and evolved over the years as well. So I never assume anymore in the first visit. So if I ask them to do the posterior elevation, the, suction hold or caves, depending on what you call it, sometimes the first visit, I'll do the range of motion scale and I'll go, oh, shoot, not very much, or they can't do it at all. But then after a few sessions and working on those lingual suction activities, I'll say, oh, it's a different number now. I've gotten them to have more elevation. I remember one patient, he came to me, he had a tongue release a year before, didn't have myo, came to me and they said, oh, it reattached. We're gonna have to do it again. Let's do myo before. And I said, oh, poor thing. He couldn't lift his tongue at all. After like 3 weeks, he showed a wonderful elevation. And I just went, oh, he just hadn't learned that ability and that skill. So one of the things I do is I don't ever assume at the first visit until we try to get more range of motion and coordination of the tongue to get a proper assessment. The second thing is it's not about appearance. Mm-hmm. It's about appearance and function. So you want to look at all the different aspects. You want to look at why would you want to have a release? I had a patient last week. The child was absolutely having all kinds of comorbidities from a tongue tie. The mother said, I don't understand why it's a big deal. My tongue looks exactly the same. She had no functional limitations. She didn't have speech impacts. Her tongue was resting on the palate. She had a proper swallow. I don't know how, but she had no functional impacts. And the child was having quite a few. So we had to dissect, okay, and are those functional impacts not going to be able to get resolved if there is, like with my son in speech for 6 years, we never resolved the ability to lift the back of his tongue. Our goal was he could say his name. The third thing I wanted to say was one of the things I do that helps me a lot, and I love this, especially when patients came into the office more, is I have a little book It's actually, it's funny. It's from Beyond the Prophy from Jasmine. She gave it to me from one of her courses. It's a little binder book. It's leather bound. It's beautiful. And when people have their release and they come in for their next session after their release and they have this is how I feel different story, they write in my book. I get the book out and I say,
I love that.
Write in my book your story, because I wasn't tongue-tied. My son was tongue-tied. My husband was tongue-tied. His mother was tongue-tied. So it comes on my husband's side. So I have relationship to the procedure through my family members, but not through myself. So I want them to learn from somebody that went through it, not just from me, not just from textbooks, not just from studies, but what did that person experience and how do I relate to that person's experience and see my experience and their experience? And this is what I'm desiring. And what's really interesting is there's the same word that comes up lots of time when they write their story. And the word is freedom. I now feel free. Even the children, the adults, I now feel free to swallow properly without stress. I now feel free for my tongue to rise to the roof of my mouth without tension. I now feel free to stand up straight without my shoulders feeling rolled forward. And so really the thing that speaks the most volume is I admit I didn't know how to see it. And then I show them other people's stories and share stories and success stories. Now, does everybody have the same story? Absolutely not. But it really resonates with.
For sure. And I totally agree with you. When I think back to assessing tethered oral tissues, 5 or so years ago, when I first became a myofunctional therapist, there's so much more to it now, right? Like I wasn't looking at the compensations that I look at now. Then, I wasn't looking at floor of the mouth, elevating. And it's crazy. And I'm sure it will just continue to change as, again, these amazing leaders are doing more and more research. And that's what we need. And we're so thankful to all of the trailblazers out there. It's always changing. We're always students. We're always going to learn something new. We can think we know it all, but we certainly don't, because you'll wake up tomorrow and you'll be like, oh, wow, I don't know that.
And I'm also thankful that the trailblazers, the ear, nose, and throat doctors, Dr. Zoggy, the dentist, Dr. Richard Baxter, Autumn, speech pathologist, they also are saying we have to work as a collaborative team.
Yes.
I am not alone in resolving this concern. We want to work with the body workers. We want to work with the myofunctional therapists. We want to work with the release providers. So I think the fact that we're working as collaborative teams, we're getting much better results for the patients, and we're unwinding the compensations and resolving the why. And for me personally, my life has so much more excitement and value because I've gotten to know my team and my friends and the conferences I've gone to. And like we talked about, it's so empowering to surround yourself with other empowering people.
Definitely. So why don't you share with us some of your most interesting cases?
Okay. Great question. I'm going to start with one of my failure cases and one of the ones that made me cry, because in the beginning of my journey, I worked as a dental hygienist in the mornings and then as a myofunctional therapist at night. So I worked from 7 to 12 as the hygienist, and then from 1 till, forever at night as the myofunctional therapist, because you're doing the clinical and you're also doing the administrative. And as hygienists, we don't have those administrative hats on. We like that front office staff that we got to send them to that did the billing and the scheduling. But so I had new eyes to see the patients, new myo eyes, but as a dental hygienist, I was supposed to only be the tooth cleaning lady. And that's what the patient expected. That's what the office expected, but that's not where my brain was anymore. And it was turmoil in my head. Like, what do I say? How do I do this? How do I just go, and not just scream like I want to? So the case that comes to mind was a little guy. He was probably only 7 years old, and he was in my hygiene chair. And I'm doing my assessment, and I see that he is tethered to the tip. He's got the worst tongue tie as far as a restriction. He could hardly even touch his front teeth.
Oh my
And so I
gosh.
tried to stay calm. And I said to the mom, so mom, what do you think about this little tongue that can't get off the floor of the mouth? And she goes, oh, yeah, okay, that's nice. I hadn't thought much about it. I didn't even know. However, we're on our way to go to the oral surgeon as soon as we leave you. I said, you are? That's interesting. Why? And she said, because the orthodontist said that he is structurally deficient. He's 7, and we're going to take his premolars out. I know. I just, it took everything I had to just still be the hygienist hat and be calm, everything I had. And I said, oh, so they were going in for the assessment. And I said, okay, so when you see the orthodontist, the oral surgeon, excuse me, can you, because the orthodontist sent them to the oral surgeon. And I said, can you ask him what he thinks about this restriction? And I explained about myofunctional therapy and the importance of range of motion. And at that office, I wasn't supposed to talk about myofunctional, but I was allowed to give my business card and say, call me after hours. I have another job where I do myofunctional therapy and I can help you with the oral function. But right now, my role is to be your hygienist. So I said, call me tonight. Let me know what the oral surgeon says. Please point out the tongue. And I want to let you know that he's still growing and we could maybe grow into those teeth and not take them out. So, but I had to be calm and keep my hygiene hat on because I can't overshadow what the doctors say, what the orthodontist says, what the surgeon says. I have no ability to be more than the hygienist. And so she called me that night and the oral surgeon told her that his tongue was fine and he needed his second molars pulled. And that he basically told her that I was wrong and I didn't know what I was talking about. And I just cried for that child. I cried because the advanced training I've had has taught me that we need to develop the palate, the roof of the mouth to accommodate the tongue. And the tongue's job is to help to make his home. He is the architect of his home. And we need the tongue to rise to the occasion to help create his home. That when I'm working with the kids, I have this crazy, I say the silliest things because I think it resonates, is I ask them, does your tongue sleep upstairs in the bedroom or is he lazy and downstairs on the couch?
Oh my gosh, I love that.
And it's like our tongue needs to sleep upstairs in his bedroom and he needs to be able to be up there. So he's out of your airway and not lazy on the couch. And so we say it every time, every meeting, where's your tongue? Is he upstairs in the bedroom, sleeping in his bed? Or is he downstairs lazy on the couch? And so like they love that for some reason.
Yeah, I love that.
You just have to be silly with these kids, right? Yep. So that was just a really sad case. So another case, I'm going to go through an evolution here with you really quick, is when we do myofunctional therapy, we learn about swallowing and chewing skills, not just tongue palate skills. So I had another patient in my hygiene chair with my hygiene hat on, and she was a beautiful, lovely 70-year-old lady, well-dressed, went to the gym, takes courses in French and does substitute teaching. She's just, and very, very, her hair was always perfect. And, you go through the medical history and you say, okay, what medications are you taking? What's happening with your health history? And she'd say, I have acid reflux. Okay. What is the doctor doing? Acid reflux meds. Okay. And you document it and you move on and you go and you take the plaque off their teeth. So next visit. How's your health? Acid reflux is getting worse. What did the doctor say? He doubled my meds. Well, you learn those meds are not real healthy. And I said, the third visit. Okay, how are you? It's worse. I've decided to stop eating solid foods. My acid reflux is so bad. I'm up to 3 to 4 pills a day. And I said, okay, time out. I'll be right back. So I went to the break room, got a cracker. I said, did they ever check the function of your chewing and swallowing? No, they heard my symptom and they prescribed the medication. I said, okay, we're going to check the function of your chewing and swallowing. Here's a cracker, chew it. And so what I do is I have them chew it. I watch their chewing techniques. And then I periodically have them open their mouth, show me what the food looks like. Like, really? Ew. I'm like, no, that's what I do. I clean plaque off people's teeth. It's nothing for me. So, and I see dry, crumbly bits. She's not bringing in the saliva because her mouth is dry from the medications. And then I'm like, okay, how do you get the food ready? She's not forming bolus. Her mouth is just dry, crumbly bits of crackers that she's downing. And I said, okay, let me teach you about bolus. Let me teach you about incorporating the salivary flow. And go home, do YouTube videos on bolus and proper chewing and all that kind of stuff. Here's my card and call me. So she is a very intelligent learner. So she took my information and she went and learned all she could. The next visit, 3 months later, how are you? I'm off my acid reflux meds. I'm now eating solid foods. And I'm like,
Oh, that's fabulous.
that's just crazy. How do we know these things? How can we help people with function that helps them overcome their symptoms beyond surgery, medications? So that's my cases as a hygienist. So my cases now that I'm myofunctional full time, I had to bust out of the office, and plus my practice kept growing. And so I was making myself crazy trying to do both. So one of my really great cases, and we all have so many, and every one of them is my favorite. So
Yep.
every week it's a different favorite. So this particular guy, I have a habit program, and so they come to me for thumb sucking habits. And he came in, he had large tonsils. I asked the mom the sleep questions. I have a survey, parent observation questionnaire that they come in with, and which helps save a lot of time. And it gives the parents time to say, wait, you're going to address this? Wait,
Yep.
I didn't think you were going to address that. Like, why is this on this question? Like, this is bringing up things that I didn't know we would talk about. And so he's snoring, he's not sleeping well. And I look down his throat to see, because it's always, as you know, Brittany, airway first.
Yep.
Breathing first. It always starts with the breath, the breathing, the sleep. So I looked down his throat, his tonsils are filling his throat. And I said, sorry, mom, you came in for the thumb, but we're not going to address the thumb. I think he's using his thumb to lower his tongue and bring his jaw forward, just like our oral appliances, to breathe. We have a bigger problem. And so we asked her, I always have them do videos of their kids sleeping and snoring. I'm sure you do the same thing.
Oh, yeah.
And so she did a video. She brought it to me. I'm like, okay, let's look at the video. All right. So he's snoring. He stops breathing. I start counting 1, 2, 3. I got to 13 before he gasped for his next breath.
Oh my gosh.
And I said, okay, mom, as soon as we're done, you're calling your doctors. We're going to go show them this video. We're going to go to the next level on solving the why he's 10 and still sucking his thumb. And so this is right before COVID hit. There was a lot of interruptions with COVID, with getting the sleep study. And then the sleep study, of course, showed he had sleep apnea, as we figured out from the video. And then he ended up having his tonsils out. So the amazing thing about it is he came in for the thumb sucking, but we didn't just resolve the thumb and take away his compensation tool that he needed. I said, I'm so proud of you. I'm so proud of you for still sucking your thumb, because you figured out how to breathe. And so I'm not going to play the blame and shame game that you're still sucking your thumb. I'm going to be proud of you because you had to breathe, you had to sleep, and you had to figure out a compensation. So he's just, I mean, one of my many, many cases on, you know, as a hygienist, I loved my patients, saw them every 3 or 6 months for 10, 15 years, depending on how long I was at the practice. Now we see them every week, every other week, and we are deep into their family. And often other family members have concerns too, because we'll see tongue ties run in the family, and our relationships are even deeper.
Yeah, it's so rewarding. It really, really is. It's, you know, we talked about this. I think we talked about this on the Clubhouse meeting last week, just how, you know, as hygienists, we're so passionate about our jobs, and it as a hygienist, it's a very rewarding job, but Myo just takes it to that extreme level. I mean, I never thought that I would be this happy, you know, in my career and be this fulfilled. It's just awesome. And it's so exciting for me. Like I said, my sister-in-law taking the course. My sister-in-law is actually a nurse.
Oh, okay, great.
Yes. So we're trying to bridge the whole medical and dental gap there. But she's like, same thing. She's like, Britt, you know, I wanted to be a nurse. And what's interesting with her is she has a degree in early childhood education, and then she went on to be a nurse. So she kind of has like a dual thing going there. And she's like, I just want more. Like, I am so passionate. She's like, I get it now. I get it why you are where you are now. She's like, I can't stop. I can't turn it off. It's all I want to think about, read about. And it's just so exciting for me to hear.
But I have a theory on that. And my daughter went to nursing school too. She was worked as a hygiene assistant for a while. Okay. So she understands dentistry, and then she ended up being a nurse practitioner. So, but my theory on that is in medical and in dental, we should all understand airway. We should all understand the importance of breathing through our nose and our tongue rest and cranial facial development. That it, myofunctional therapists can be like the physical therapist for the orthopedic surgeon, where we do function and rehabilitation for the person that's doing the structural,
Right.
correction.
Mhm.
We should have myofunctional therapists to help people with that therapy part. Because believe me, in medical, they don't have time to be,
Right.
putting as much time in intensive rehabilitation of habits that we
Mhm.
do, but we should all understand it. And I think it should just be taught. I do a lot of speaking now, and I speak at hygiene programs. I speak at study clubs. I'm speaking at Midwest convention coming up in April. I'm so excited, but I just want to spread the word that we should, this is something that should be in our training. We should all, medical and dental, understand it. And then on that same note, I don't think dentistry we should be specialists of teeth. We should not be denticians. And I was thinking about that this morning, that most dentists, that when we put our little sign out front, it's of a tooth,
Mhm.
that we are specialists of the teeth, but we are so much more than that. We are specialists of the oral health, the complex where we eat, we drink, and we breathe from. And we are the ones that see everybody every 6 months in a position with a light that we can see things much bigger and better and brighter than most medical professionals. And working as a collaborative team, we can do amazing things through the lifespan of the patient.
Oh my gosh, 1,000%. It's funny. I just spoke with a group of hygienists and they were like, well, just tell me, make me a little cheat sheet. Like, what do I have to look at? And I'm like, you're already looking at it. You just need to learn to connect the dots and understand why you're seeing what you're seeing and how that, plays out in the rest of the body.
It's like that two sides of the coin of
Yeah,
our palate, right? Are we looking at the airway? Are we looking at the palatal shape? We're looking at the same
same thing.
thing. We just have to, if we have our eyes and our vision open up a little bit, it's very exciting. And it adds so much value to our worth and our day, because
1,000%.
we change lives. We change lives. It's really, I tell the patients all the time, I really could care less about where your tongue is or how you swallow. But what I care about is how it's impacting your life, how it's impacting the orthodontic treatment you have to do 3 times, or you're
Mhm.
snoring because the tongue is falling in the back of the throat. What I care about is you being the best you can be, the best quality of life you can have, and how these simple things, tongue up, lips closed, breathe through your nose, impact your life.
For sure. And talking about, you mentioned orthodontics and palate size. So if we want to talk about, as myofunctional therapists, we focus a lot on and stress early intervention and expansion. So if you want to talk about the value that you see in collaborating with orthodontists pre orthodontics, I guess I should say, even pre like expansion, I guess.
So I'm super, super fortunate that I have amazing orthodontists that I work with that have learned to trust me. And, once they see, and I'm sure you've experienced this, those cases that they go, I didn't know that was possible. I have that little side story. I spoke for a group of dentists one time. It's so funny. The dentists that were there, they're still laughing about it. So there was about 20, there was 2 sets of tables of 10. And one was doctors that had understand function and they were very progressive dentists. And there was other dentists that had never heard of myofunctional therapy and what we do. And I was showing them my before and after cases of the impact of oral rest posture on the teeth, especially when they're in that phase of life when the teeth are trying to find their home, when they're 4, 5, 6, 7, well, not 4, because their permanent teeth are erupting. So 6, 7 years old, you can get that tongue in the right position, get rid of that thumb, and you can see shocking results of how much the open bite can close, or just the development changes. I've seen, maxilla change, and it's just so fun. I take pictures all the way along so that it's documented, and I measure and take pictures because I'm surprised what I see. In the beginning, I was shocked. So I had this one dentist, he literally stood up in the middle of my presentation and he said to the other doctors, he said, "Do you believe a word she's saying? Do you believe she's really getting those results by just changing oral rest posture and getting rid of a habit or whatever's going on, and not with orthodontics?" I've seen 5 millimeters of movement of close of open bite. And the other dentists were like, yes. And she knows what she's talking about. And you really need to listen and absorb what she's saying. So it was really fun because
Yeah.
I'm used to this now because it is shocking. I told them I'm surprised. So I'm going to tell you, even I'm surprised. That's why I take pictures. So the orthodontists I work with, I do a lot of speaking. I do a lot of presenting in their offices. I show the cases and we work really well together. A lot of the orthodontist office, they don't want to do expansion, the rapid palatal, until the first molars are in. And so then we kind of have this little gap when I get them at 4 years old and they're very, very narrow and they have a wait and watch. And I'm like to the parents, no, we need to take advantage of that growth period. And then the orthodontists I work with are supportive of me having them see people that go to the additional training to learn ALF or MyoBrace. I've had the privilege of learning under Airway Health Solutions about solutions that we can have as early as possible. And they are supportive of, hey, let's see what we can do between 4 and 6 before this first molars. I support anything you can do. And then when they come back to the orthodontist at 6, then they're ready for their rapid palatal and they're thrilled because the orthodontist, they really don't want the foundation that those teeth are supposed to go in to be too narrow. Too small. They don't, because they need to move those teeth into the home that those teeth are living in. And so they are thrilled and very supportive of building that foundation for their orthodontic plan. And they are very supportive of the muscle pressure to be in balance, because the tongue and the lips are actually more powerful than the orthodontic bands. Sometimes I've seen 2 cases where the habit appliance was literally broke off in the child's mouth because of the tongue still pushing on that habit appliance.
Yeah.
And that was not a good day. So I guess to answer your question is communication, collaboration, learning from each other, being open. And from their perspective, I need to understand their perspective, understand why, if a child doesn't come to them till 15, why they feel like they don't have enough room for those teeth. And so that's my answer in a very long-winded way.
Yes. And I think the emphasis on that is just collaboration, and communication is the basis of it. We're working as a team. It's definitely a team effort. One last question that I want to ask before we wrap up, because a lot of hygienists that become myofunctional therapists, they always feel a little bit iffy when it comes to working with patients that present with TMD symptoms. So I guess my question to you is, do you work collaboratively on patient cases with TMD? And if you can share like an example of 2 to 3 exercises that you think TMD patients benefit from?
Great question. I have had the extreme privilege of getting to know a lot of doctors that work with TMD, and the Dawson Academy, which is a national organization, might be international organization for training with dentists. I am the speaker at their advanced TMD training course, their national course, and have met some amazing doctors and collaborated with amazing doctors. And I think a 2 or 3 day course, and they bring me in as a guest speaker. And so I bring in the perspective of oral function to really understand oral function in combination with, the scans that they're doing and the measurements, and they're really looking at the structure and the occlusion. And so I bring in a new element. And so it has really been fun for me to combine with that course, and fun for all of us. And so now a lot of us work together collaboratively with the patients, and they'll say, Cheryl, I've got this case. You've got to help me with this case. I see it through my perspective. What is your perspective? And so my perspective always starts with, what is their function? What are they doing with their jaw? Are they compensating with their jaw? Are they moving it in direction? So for example, a lot of it starts with tongue ties. So a lot of it, if they have restrictions, they're compensating with their jaw to help their tongue move. So what I say is, if this finger, my middle finger is the mandible and this finger is my tongue. And if this webbing was all the way to here, they move together as pairs. We wouldn't send a baby home with their webbing between their two fingers or index and their middle finger because they wouldn't be able to use scissors or pencils. So what's happening is, do we have compensation with the jaw? Where is the tongue? Is there tension? So I work a lot with getting the patients to breathe diaphragmatically, because if they're mouth breathing, thoracic breathers, they're holding a lot of tension and their jaw is in the wrong position with the oral breathing, with their jaw dropped. So we always start with breath. We always start with breathing. We start with eliminating the stress and tension off their face. We do disassociation exercises. So how can I use my tongue if we get a release or not without involving the mandible? So we do a lot of exercises to give, I call it the tongue independence, to move without the jaw. And then of course we work with oral rest posture. One of my favorite exercises, of course, the lingual palatal suction to get the tongue on the roof of the mouth, and then suction bite. So when you're doing the suction bite exercise, you know you're working on jaw stability, and then having the tongue move in different positions without the jaw following. So really, it always comes down to airway, breathing, changing them out of a high stress living and sympathetic nervous system. Sometimes it's sleep hygiene. You know, if you aren't getting good restorative sleep, then you are not, it all works together collaboratively to somebody staying tense and tight and not being able to relax those facial muscles and work those muscles in harmony without compensations.
That was a fantastic answer. I love everything about that.
Thank you.
And you know, as so many of these patients that we see, you know, with TMD have a lot of, you know, sleep disordered breathing, over breathing, chronic anxiety, and they're not
I
really
see
understanding
so
where
much.
it comes from.
Yeah, chronic anxiety is just huge. COVID didn't help that any.
Oh yeah, no.
And wearing masks. So, you know, we could have a whole episode on,
Oh my gosh.
children and the adults are wearing masks all day and they're like, I can't breathe because I can't breathe in my mask. But a lot of them are wearing cotton masks that were made that were really designed to breathe through.
Right.
And, they're not really, those fabrics aren't meant for air to go in and out.
Right.
And so we could do a whole
other episode, and we're
gonna on how they're holding their jaw to bring the mask down and shifting things around. And
we should have you back, and we'll talk a lot about the, you know, things that people can do, because so many people bring that up. I mean, even other professionals, there's a ton of hygienists that are always asking me, I never realized how much I breathe dysfunctionally when I'm wearing a mask. So I love that idea. Is there anything you want to say before we wrap up? Anything you want to leave the listeners?
Can I leave us with a quote?
Yes. Oh, I love quotes. Do you see my wall right here? I have like really wall quotes.
So I love quotes too. And I came across this quote and I just, I think it kind of summarizes everything we're talking about, because I love the trailblazers. I love the people I have met. I love the people that have written, you know, Gasp and 6 Foot Tiger and Jaws and Dental Diet. And, you know, I'm following all of them. And I've had the privilege of getting to know, you know, a lot of these doctors, Dr. Zoggy, and the research that he's doing. And I remember talking both to Dr. Zoggy and Kevin Boyd about 5 years ago, and the beginning of this exponential journey that we're on with airway and oral function. And both of them kind of said how they were hitting walls of people not really being on board, and they were kind of trailblazers with these new ideas. And now everybody's on board, and it's just been wonderful. But in the beginning, they were people that are going into new avenues are hitting brick walls, and you have to decide, am I going to climb over that brick wall and keep going, or am I going to just let it stop me? So this is a quote that I want to end us with by Steve Jobs, and everybody knows who Steve Jobs is, right? So here we go. Here's to the crazy ones, the misfits, the rebels, the troublemakers, the round pegs in the square holes, the ones who see things differently. They're not fond of rules. You can quote them, disagree with them, glorify or vilify them, But the only thing you can't do is ignore them, because they change things. They push the human race forward. And while some may see them as crazy ones, we see them as genius, because the ones who are crazy enough to think that they can change the world are the ones who do.
Oh my gosh, I love that. I just got the chills.
But
That
I
is
guess I'm
fantastic.
so excited that we're on this wave of really recognizing breathing and sleep disorders and
Mhm.
how it impacts our life. One last thing is, I'm also thankful, and I saw you interviewed him, James Nestor, who wrote Breath. And
Mhm.
I'm thankful for him because he's brought a lot more attention to basic consumers. So, he's on a lot of podcasts, he's been on news stations, and he is a science journalist. He is not a dentist or a doctor. So his book is so entertaining to read
Yes.
from all kinds of different genres and all kinds of different people. And he just is so humble and just says, I was on a journey to understand the impact of healthy breathing. And it's just, all these pioneers are just bringing us into a healthier place, because we need it, because sleep and airway disorders is an epidemic that
Mhm.
needs to have attention.
1,000%. Cheryl, thank you so, so
Thank
much.
you
This
for
has been
having me.
yes, this has been so great. You offered so much knowledge, and I can't wait to have you back on again.
And I'm glad
We
to have
really
you as a
do.
friend.
Oh, me too. You're the best.